Hello, my name is Jordan Miller. This presentation was completed for the fall semester of 2017 for Principles of Epidemiology at the University of Kansas. My interest for this project was to analyze the relationship between obesity and polycystic ovary syndrome, which is also known as PCOS. Reproductive, hyperandrogenic, and metabolic dysfunction associated with polycystic ovary syndrome increases a patient's risk for infertility, depression, anxiety, type 2 diabetes, dyslipidemia, and fatty liver disease. These conditions pose a public health concern in this patient population and can have a negative impact on their quality of life and also healthcare costs. Obesity is a modifiable risk factor. Therefore, if a strong association can be found between BMI and PCOS, weight loss could reduce these costs and, more importantly, alleviate the patient's symptoms. According to the Center for Disease Control and Prevention, more than 1/3 of U.S. adults are obese. Obesity-related conditions include some of the leading causes of preventable death, like heart disease, stroke, type 2 diabetes, and some types of cancer. In 2008, the estimated annual cost of obesity in the U.S. was $147 billion. PCOS is the most common endocrine disorder in women of reproductive age. In the literature, several comorbidities have been associated with PCOS, including cardiovascular disease, diabetes, bipolar disorder, and obstructive sleep apnea. These factors represent a major health and economic burden. The association between obesity and PCOS was researched, and 3 articles will be analyzed in the upcoming slides. Study number 1 is a community-based longitudinal observational study that was conducted in Australia over 10 years. The main outcome measures, BMI and PCOS, were both self-reported. Self-reported PCOS was correlated with irregular menstrual cycles, a key clinical feature of this condition. Odds ratio was the measurement of association used in this study, and 2 odds ratios were reported that I felt were pertinent to the exposure of interest. The odds ratio of reporting a higher average BMI in the cohort with PCOS was 1.09 and 1.7 for those that reported a weight considered overweight. Although neither represent a strong association, these odds ratios do represent a positive association between a higher BMI and PCOS. The main results from this study are that women in the PCOS cohort had a higher weight, mean BMI, and greater 10-year weight gain compared to the non-PCOS cohort. Another interesting statistic revealed in this study is that the risk of reporting PCOS increased by 9.2% for each BMI unit. The strengths of this study include a large sample size of 8,612 women. There was also a high participation rate of 60%, and the use of longitudinal data was also helpful. Limitations included reliance on self-reported data, and all of the studies have a potential for diagnosis bias, considering obese women may be more likely to be screened and then diagnosed with PCOS compared to women of normal weight. Study number 2 is a population cohort study that was conducted during 2009 and 2010. Eligible women were identified using the Louisiana Medicaid Claims Database. The main outcome measures were obesity and PCOS, or key clinical features of PCOS, including infrequent or absent menstrual periods with hirsutism, which is abnormal hair growth on the face and body. Odds ratio was again the measurement of association expressed in this study, and at 5.9, it revealed a strong correlation between obesity and PCOS. Other outcomes measured in this study included cardiovascular risk factors such as diabetes, anxiety, depression, eating disorders, infertility, and obstructive sleep apnea. The results of this study did reveal that women with PCOS were more likely to have a diagnosis of obesity and other comorbidities such as those we just mentioned. A few strengths of the study included a large population of 6,756 women, low cost to conduct the study, and it was unobtrusive to the patient. There are obvious weaknesses and limitations to utilizing databases and medical records to collect data. The accuracy of the data is dependent on clinician input and diagnostic coding. Study number 3 is a prospective cohort study that involved all female births in 1966 in the two northernmost provinces of Finland. Participants were surveyed at ages 14, 31, and 46. The outcome measures of interest in this study are obesity and PCOS. BMI was clinically measured or self-reported. PCOS was defined as infrequent or absent menstrual periods with hirsutism at age 31 or a formal PCOS diagnosis by age 46. Odds ratio is again the measurement of association that was utilized in the study. And at all three ages that were surveyed, there was a positive association between BMI and PCOS. Weight gain, especially in early adulthood, was found to play a critical role in the emergence of PCOS. Long follow-up and high response rates are among the strengths of this study. Limitations include self-reported symptoms and diagnosis of PCOS. All of the studies have reporting bias. Study 1 and 3 due to the self-reporting of the measures of interest, and Study 2 due to possible abstraction of inaccurate data that was entered into the databases and medical records. Studies 1 and 3 have recall bias due to incomplete or absent responses from participants. As mentioned earlier, all three studies have the potential for diagnosis bias since obese patients may be more likely to be screened and diagnosed with PCOS when compared to women of normal weight. In study number 2, participants were selected from the state's Medicaid database, which could have led to selection bias. Dysmetabolic and endocrine abnormalities associated with PCOS could represent biological plausibility. Studies 1 and 3 were conducted over a span of time and showed temporality. While the confidence interval of all studies show a statistically significant association between the exposure and outcome, the odds ratio of 5.9 in Study 2 demonstrates the strongest correlation. PCOS and obesity are associated with multiple comorbid conditions that can negatively impact a patient's quality of life and healthcare costs. This can cause major public health concerns. The 3 research studies that were reviewed revealed that the odds of the exposure, obesity, was greater than that in controls, determining that there is an increased risk of developing the outcome, PCOS. Although some biases and biologic plausibility raise clinical questions that should be considered. There are metabolic components associated with PCOS. Study 2 found an odds ratio of 26.49 for dysmetabolic syndrome in the PCOS cohort compared with controls. Could PCOS be the exposure and obesity the outcome? Despite these clinical questions, confidence intervals and odds ratios revealed in these studies, along with their consistency with other research that has been conducted, supports a causal relationship. Clinicians can use this information to educate patients with PCOS about weight loss to alleviate their symptoms and improve their quality of life while also reducing healthcare costs. Future research should explore the pathophysiology interactions between obesity and PCOS, future risks for cardiovascular disease, correlation with abdominal obesity in particular, and the role of weight management during adolescence and early adulthood to postpone or possibly prevent the symptoms of PCOS. The effectiveness of specific weight management techniques to improve PCOS symptoms should also be considered. Thank you.